Vernal keratoconjunctivitis. Definition: it is recurrent bilateral allergic inflammation of the conjunctiva. Etiology: it is hypersensitivity reaction to the exogenous allergens which act as antigens. It involves type 1 and type 4 hypersensitivity reaction. Age 15 to 5 to 15 years. Sex more common in boys than girls. Season common during summer and spring. Family history: 2/3 of patients have close family history of atopy. What is atopy? It is a genetically determined predisposition to hypersensitivity reactions upon exposure to the specific environmental antigens. Pathogenesis: exogenous allergens act as an antigen and reduce the IgE antibodies. IgE antibodies and antigen reaction occur on the surface of the mast cells, causing degranulation of the mast cells with the release of chemical mediator histamine, serotonin, and slow releasing substances. The chemical mediator produce inflammatory symptoms and signs in the conjunctiva and cornea. Clinical types: there are 3 types: palpebral type, bulbar type, limbal type, and mixed, both palpebral and limbal. Symptoms: they are more or less same in all 3 forms of include bilateral involvement with recurrent itching is the main presenting feature. The other symptoms are lacrimation, photophobia, foreign body sensation, and increased blinking. Signs: they depend upon the type. Palpebral form, hyperemia. It is characterized by hyperemia of the conjunctiva, diffuse papillary hypertrophy, predominantly on the upper tarsal conjunctiva, large papillae with flat-topped polygonal appearance resembling cobblestones and pavement stones. Fashion is typical feature. Giant papillae develop in severe cases when papillae undergo hypertrophy to produce cauliflower-like excrescence. Exudate is mucoid and sticky. Robbie secretion characteristic of vernal catarrh. Robbie secretion characteristic of vernal ptosis may occur due to increased mass of upper lid. Limbal form: it is characterized by hyperemia, edema of the limbal conjunctiva, gelatinous papillae on the limbal conjunctiva, Trentus dots are discrete white superficial spots composed of predominantly of eosinophils which may be found scattered around the limbus at the apices of papillae. Mixed form: it is characterized by the feature of both palpebral and limbal form. Keratopathy: corneal changes is more frequent in palpebral form. The punctate epithelial erosion is earliest finding. Punctate epithelial erosion is the earliest finding. Epithelial macroerosion and ulceration are due to toxin released from the inflamed conjunctiva. Plaque and shield ulcer is caused by epithelial macroerosion in which the bare area becomes coated with a layer of desiccated mucus. Subepithelial scarring usually occur in the form of rings. Peripheral superficial vascularization may develop due to chronic inflammation. Keratoconus is more common in VKC. Treatment: avoid the exposure to allergen. Cold compress may be helpful. Muscle stabilization are quite effective in controlling the VKC and can be used for a long period because they do not have the side effect of steroid. Sodium chromoglycate 2% to 4% drop 4 times. Lodosamide stabilize both mast cells and eosinophil cells. It is superior to sodium chromoglycate. Antihistamics such as imidazostine and epinestine are used to control the itching. Non-steroidal anti-inflammatory drugs such as ketorolac, diclofenac may improve comfort by blocking non-histamine mediator are effective in some patients.